Hello, my name is Dr. Dewan S. Raja. Today I will discuss about the development of the thyroid gland. The thyroid gland develops as an epithelial proliferation in the floor of the developing pharynx. At the junction between the tubercular implant and the hypobranchial eminence, also called copula, of the developing tongue, that is located at the junction between anterior 2/3 and the posterior 1/3 of the tongue, at a point later indicated by foramen cecum. So it's because it is coming from the epithelial proliferation of the floor of the developing tongue, it is mostly endodermal. The developing thyroid descends through the substance of the developing tongue in front of the hyoid bone, in front of the larynx, and ultimately reaches to the upper tracheal ring by 7th week of development. So the developing thyroid gland descent. It initially descends as a hollow thyroglossal duct that becomes solidified and bilobed. So it descends through the tongue in front of the hyoid bone, in front of the laryngeal cartilage, and reaches to the upper tracheal rings by 7th week of development. Okay, it becomes bilobed. It has two lobes, left lobe, right lobe, and these two lobes are connected by isthmus and is connected to the tongue by thyroglossal duct in the development process. Then the thyroglossal duct disappears. We may get another lobe that is called pyramidal lobe that extends from the isthmus to the hyoid bone by muscle or by fibrous tissue. We call it pyramidal lobe, that may or may not present in many cases. Okay, so this is the foramen cecum, the junction between the tuberculum impar and the copula or hypobranchial eminence of the developing tongue. Okay, then it descends to the substance of the tongue in front of the hyoid bone, in front of the laryngeal cartilage like thyroid cartilage, cricoid cartilage, and goes in front of the upper tracheal ring. Suppose the isthmus is against tracheal ring number 2, 3, and 4. Okay, so this is the passage of the developing thyroid gland. This is the ultimate adult location, or after birth developed location of the thyroid gland, and we may get a pyramidal lobe here, may or may not get it. Okay, so this is from foramen cecum. Here is the foramen cecum, then it settled here. So this passage, the thyroglossal duct, will disappear usually, but it may not disappear. We may have the remnant of thyroglossal duct. Okay, so sometimes we get the ectopic thyroid tissue in the tongue. We call it lingual thyroid. It may be in sublingual position, sublingual, lingual thyroid. We may have scattered thyroid tissue in front of the hyoid bone. Okay, so we may have well-defined pyramidal lobe. So these are the ectopic sites of thyroid tissue. Let's go to the histogenesis of thyroid gland. Thyroid gland has two types of cell. most of the cells are follicular cells. These are endodermal. They produce colloid, and these cells are very essential for the synthesis and iodination of the tyrosine to produce the thyroxine T4 and triiodothyronine T3, and they produce colloid inside the follicle. The thyroid gland begins to function at the end of the 3rd month of development. We have another type of cell, the parafollicular cell. They are present in between the follicles. They are also called C cells. These cells are derived from the cranial neural crest. These are found between the follicles and are derived from the ultimobranchial body, also called ultimopharyngeal body. The ultimobranchial body or ultimopharyngeal body is developed from the ventral region of the 4th pharyngeal pouch. Okay, it is found in the ventral region of the 4th pharyngeal pouch, but it is told that this is the remnant of the 5th pharyngeal pouch. The 5th pharyngeal pouch disappear in human. It is incorporated in the 4th pharyngeal pouch as ultimobranchial body. Okay, that will give rise to the formation of parafollicular cells, which are cranial neural crest origin. The parafollicular cells secretes calcitonin, also called thyrocalcitonin. This thyrocalcitonin actually decreases blood calcium level. They put back the calcium in the bone. Their action is different from that of the parathyroid hormones. Just opposite the action of parathyroid hormone. Parathyroid hormone increases blood calcium level. Calcitonin decreases blood calcium level by putting back the calcium from the blood to the bone. Okay, so this is the anterior view of the thyroid gland. In the posterior aspect, we'll get 4 parathyroid gland. Okay, this is the superior parathyroid gland, inferior parathyroid gland. Inferior parathyroid gland may go further down and it may not be on the thyroid gland posterior aspect. Okay, this is the posterior view of the dorsal aspect of the thyroid gland. This is the anterior ventral aspect of the thyroid gland. This is the isthmus connecting the 2 lobes, the left lobe, right lobe. Okay, so this is the isthmus area. This is against the tracheal ring 2, 3, 4. We got that. Now, here is the histology of thyroid gland. We are looking at follicle. Follicle has follicular cells, very essential for the thyroid pump, synthesis of the monoiodothyronine, diiodothyronine, triiodothyronine, thyroxine. This is colloid protein. So T3, T4 are present in the colloid. Okay, so this is the follicle containing colloid protein containing T3, T4. Okay, in between the follicle we have the C cell. There is the parafollicular cell. They are coming from the ultimobranchial body, also called ultimopharyngeal body. They are derived from the cranial neural crest. So they are cranial neural crest origin. Their purpose to produce the formation of the calcitonin, also called thyrocalcitonin, that actually decreases the blood calcium level, put the calcium inside the bone. Okay, congenital anomalies of the thyroid gland, will go there. Congenital anomalies, we may have thyroglossal duct cyst. This duct, initially a hollow structure that is solidified, then it is bilobed in the lower part. We have isthmus. This duct may not disappear. There may be a cystic swelling. There will be collection of localized fluid in the remnant of thyroglossal duct along the migratory path of the developing thyroid. migratory path is from the foramen cecum to the tracheal rings. Okay. Thyroglossal duct cyst may communicate with the skin, maybe due to rupture. There may be just the separation of the skin in front of the cyst that will lead to the formation of fistula. Fistula is communication between two surfaces. Okay. Cyst is the collection of fluid. All the thyroid anomalies are midline structures and are a common anomalies of the neck. Okay. Okay. So aberrant thyroid tissue may be found anywhere in the path of descent of the developing thyroid and is more common in the substance of the tongue beneath the foramen cecum. So this may be the only one thyroid structure in a person. So it should not be taken out because it is functional, and it may go through all the diseases of other normal thyroid, may go through hyperfunction, hypofunction, may go through cancer. So someone may have only lingual thyroid gland, so we may not get thyroid gland in front of the trachea and thyroid cartilage. It is in the substance of the tongue. That may be possible on rare occasion. We may have sublingual thyroid gland. We may have multiple thyroid gland in the passage of thyroglossal duct. Another congenital anomaly is the congenital hypothyroidism or cretinism. This may be this is caused by agenesis or malfunction or defective formation of the thyroid gland during the fetal life, and it is manifested during infancy and early childhood. We call it cretinism, congenital hypothyroidism. Okay, there may be absence of thyroid gland, there may be defective thyroid synthesis, there may be mutation, there may be receptor of thyroid stimulating hormone may be resistant. Okay, so there are many causes, or there may be lack of iodine in the diet of the mother during pregnancy that may lead to congenital hypothyroidism or cretinism. Okay, so here we are looking at the sublingual thyroid. Okay, by scanning we are getting the sublingual thyroid here. We are getting sublingual thyroid. It may be lingual thyroid. Okay, so this may be the only one thyroid tissue, that is also possible, and it may function totally normally like a normal individual. Okay, we got that. Now we'll go to the congenital hypothyroidism. What is that? A thyroid deficiency that occurs during the fetal life owing to the iodine deficiency in the maternal diet of the pregnant women. Okay, thyroid agenesis or mutation involving the synthesis of thyroid hormone. There may be mutation in the thyroid stimulating hormone receptors also. Clinical feature like this: low birth weight, certainly mental retardation, low IQ. Okay, we may have low IQ also. There is a possibility also. Okay, so low birth weight, low IQ, retarded skeletal growth, large tongue. We will get macroglossia, large tongue. Okay, disproportionate soft tissue growth. So we'll get a plumpy, small infant. Okay, pot belly, abdomen is protruded, pot belly, belly appearance, dry, rough skin like that of hypothyroidism feature. Okay, and certainly mental retardation. But this can be preventable. It should be identified very soon after birth. Blood should be drawn. Thyroid function should be tested immediately. That is tested in the United States, in all the states, and the thyroxine should be replaced from the very beginning of life so that we can prevent the damage to the system, especially the nervous system, the myelination and branching of the neurons. will be appropriate by supplementing thyroxine, and that is a lifelong therapy. It can prevent mental retardation and cretinism. Okay, so development of the parathyroid gland. We'll go to the development of parathyroid gland. Endodermal epithelium of the dorsal region of the fourth pharyngeal pouch differentiate into superior parathyroid gland. So to remember that from fourth pharyngeal pouch we are getting the superior parathyroid gland. From the third pharyngeal pouch we are getting the inferior parathyroid gland. The superior parathyroid gland is separated from the wall of the pharynx and reaches to the upper part of the dorsal aspect of the thyroid gland. Okay, we got that. The endodermal epithelium of the dorsal region, the third pharyngeal pouch, differentiates into inferior parathyroid gland. It is detached from the pharyngeal wall and attaches to the lower part of the dorsal aspect of the thyroid gland, but it may go further down. It may go to the superior mediastinum because it follows the thymus gland. So the location of inferior thyroid gland may be further down. Although it develops in the third pharyngeal pouch, it may reach to the level of the superior mediastinum. We may not get inferior parathyroid gland on the dorsal aspect of the lower part of the thyroid gland. The descent of inferior parathyroid gland is much more and variable than superior parathyroid gland, and it is pulled by the descending thymus. About the development of the thyroid and parathyroid gland and congenital anomalies. Okay, if you have any question, please feel free to ask me. Please share the information with your friends. Please support my channel. Please subscribe me. Have a nice, wonderful and blessed day. Bye now.